Hello, I'm Dr. John Cruz, and today I'm going to be talking about amphetamine-induced psychosis. Some of this is in my book, Recognizing Adult ADHD, What Donald Trump Can Teach Us About Attention Deficit Hyperactivity Disorder. No, I did not intentionally plan this talk on psychosis the week that COVID cases are peaking and or ramping up. Probably almost definitely not peaking, and the US election is here. That was a coincidence. So I'll be talking for about 20 minutes. If you have questions while I'm talking, you can type them in on Facebook Live. This will be posted on YouTube as well later, and I will be available for questions at the end. So to start off with, what is amphetamine-induced psychosis? So this is a state of psychosis, and I'll explain a little bit more what that is induced or brought about by taking amphetamines, and I am including street amphetamines here, including cocaine and methamphetamine, and prescription stimulant products, including focused primarily on Adderall, which is a mixture of dextroamphetamine salts, dextro and levoamphetamine salts, and or dexedrine. How much this applies to other stimulants like Ritalin-based products, I will also be talking about. So like psychosis is a loosening of connections to reality. The amphetamine-induced psychosis in particular is characterized by hyperactivity. People are walking around in an agitated physically state, shaking, tremoring, talking really fast. Usually sleep is particularly inhibited. And some people have called this state of amphetamine-induced mania because it looks like someone's energetic, talking fast, talking rapidly. I prefer the term amphetamine-induced psychosis because every single case that I have seen, and I've seen a few dozen, involves intense states of paranoia where someone is suspicious that friends, family, random strangers around them are plotting against them, doing evil things, have nefarious and not just our garden variety conspiracy theories. And I have not seen any of the grandiosity, elevated, happy, exaggerated, silly mood. I've just seen fear, anxiety, craziness. So to begin with, I'll sort of put this in the framework. I've been to dozens of lectures by ADHD experts, and when they talk about the risks of stimulant medications, what they'll usually talk about is the risk of addiction, which we know happens in 2 to 4% of kids and probably a lower rate in adults. They'll talk about the extremely rare risk of sudden cardiac death for the very rare individuals, close to 1 out of a million, maybe a little more than that, who have a genetic predisposition and drop dead. They'll talk about the common side effects that are usually reflective of just too big a dose, of being mildly agitated, dry mouth, appetite suppression, sometimes excessive sweating, sometimes insomnia. And then they'll say, oh, and then there's amphetamine-induced psychosis. This happens about 1 out of 1,000 people. Let's look the other way and not even discuss it. It's so uncommon. And again, I'm exaggerating not much at all. That's how I've heard all the presentations on amphetamine-induced psychosis. And the fact that I think most experts and most practitioners are making not much to do about this is when I give a version of my lecture, which I'm going to give in the next 15 minutes, to new patients, even patients who have been on stimulants for a long time, including patients who have been with renowned experts. Most of them will say, oh my God, this is new information. Nobody really explained this to me. And often, even in the popular media, the segment that likes to demonize the existence of ADHD or the talking about ADHD or the prescribing for ADHD makes a big to-do about addiction and sort of blurs amphetamine-induced psychosis into addiction when I think they're pretty clearly separable problems. I mean, you can have both of them, but you can certainly have one and not the other. So why I think this is a topic worthy of at least our 20-minute talk right now is that the first thing, this is not just an intoxication state. And by that I mean most of our substances, including alcohol. If you drink enough of it, you can become really out of it, not aware of what's going on, belligerent, saying all sorts of things, trashing furniture, beating people up. And when that wears off, you fall asleep, or you usually fall asleep, then it wears off, you wake up in the next morning, you may have a hangover, you probably have a hangover, but almost certainly you are not belligerently screaming at people have no awareness of where you are, what you're doing. So again, the problems with alcohol and many of our other drugs are more problems with being intoxicated. And while the amphetamine-induced psychosis can start while the drug is still in your system, what's particularly scary about it to me is that the classic pattern is that it persists for days, weeks, sometimes even months or even years without subsequent additional dosing. So this can be and that's telling me that at least in these people, we are having a semi-permanent or at least a longer term effect than just, again, acute intoxication. So that to me is really scary or worrisome. People should be warned about this before starting stimulants. Second thing is the long-term picture. So one thing that's surprisingly sad, and yes, rare events are hard to study, but again, given the seriousness of this one, I think our field has been negligent in not studying it enough. So there are very few long-term studies. Most of the data that I've been able to collect has been looking, actually more often people concerned about amphetamine-induced psychosis, but cannabis or alcohol-induced psychoses. And both of those can induce longer-term states. Both of those are used more widely than the stimulants, even, across industrialized Western countries. But some of the studies have broken down long-term psychosis or risks of long-term schizophrenic-like pictures from marijuana, alcohol. So of people who present to a hospital with an amphetamine-induced psychosis, the data suggests that if you look 10 years out, probably about 20% of those people are in a permanent psychotic schizophrenic-like state. Maybe at 20 years out, 25% of these people. What we don't have data on are these people who continued using, and that's contributed to them falling into this as a permanent state, or were these, some of them at least presumably were single-time bad episode that long-term consequence was they wind up in a permanent psychotic state. None of the studies that I've looked at could, broke it down into, year 2, 3, 4, 5, how many of them were in this permanent state. But regardless, this is an alarmingly high risk for such a serious, horrible outcome. Third factor why I think this is problematic, and I'll be talking a little, is that, again, most of the researchers or lecturers I've heard talking say, oh, this happens about 1 out of 1,000 times. That's not very common. One is, for something this serious, 1 out of 1,000 isn't particularly rare. That's common. 2 is that in my practice, and I'll get into it right away, why my practice is skewed, the rates I've seen have been closer to higher than 1 out of 100, less than 1 out of 10, but substantially higher than the 1 out of 1,000 risk. So first of all, that 1 out of 1,000 risk has been based not on a lot of large historical data. There have been a few studies in recent years, and one reassuring study, and this was done on the whole Swedish population. I'm forgetting the author's last name, it begins with an H. They looked at Ritalin use, so methylphenidate use, and they did not find any particular increase in psychotic syndromes following people who were using Ritalin methylphenidate for ADHD. Presumably some might have been using Ritalin for other reasons, including weight loss. But they found in a population-wide study, and the Scandinavians in general have extremely good records for the whole population, no increased risk from Ritalin methylphenidate. However, a few other studies recently have shown rates for amphetamine, so this is Adderall-like products, things like Vyvanse, things like dexedrine, dextroamphetamine, mixed amphetamine salts, rates that are actually higher than 1 out of 1,000 and closer to 1 out of 400, 1 out of 500, 1 out of 600 in the different studies. Again, most people will not get this, but again, for such a bad outcome, people need to be warned about this. So the detail, my own practice is skewed. So part of why I got aware of this is that, and I just checked my first records of stimulant use going back to 1994, and within the first 22 patients I treated in first few years of treatment, 2 of those 22 wound up with amphetamine-induced psychoses. Both were on, neither were on Ritalin, they were on dextroamphetamine-based products, and they were not on excessively high doses. Again, so it was so alarming that that's why I've been more attuned to it, but why my practice is skewed. One is I've worked with a large number of HIV positive men over the years, having an office in the central part of San Francisco where there are high rates of lots of gay men and lots of gay men who had HIV. For those of you who weren't around or don't remember the early stages of the HIV epidemic, this is a virus that does infect the brain. Actually, a third of people presented with symptoms that were psychiatric symptoms, not with opportunistic lung infections, not with Kaposi sarcoma, but a third of presentations with HIV in the early days were psychiatric symptoms. So this is a this is a virus that can hang out in the brain. Presumably that would make some people more vulnerable to developing a psychosis when exposed to a drug that can trigger that. Clearly I've had lots of HIV positive men who did well on stimulants, so I don't think that's a complete contraindication, but it's part of why I think my population is skewed. Secondly, and closely overlapping with HIV, but clearly a separable phenomena, is in the gay community, the abuse of street methamphetamine is clearly higher than in the general population. And we do know, at least the available data suggests, that both cocaine and methamphetamine, which is chemically distinct from amphetamine, dextroamphetamine, levoamphetamine, methamphetamine, an extra methyl group added on, has substantially higher rates of abuse, substantially higher rates of addiction, and substantially higher rates of psychosis. But again, working with the population that has higher use of meth, and including the very first case of amphetamine-induced psychosis I saw was in a man, clearly he had ADHD. I'll maybe get into his history a little longer, but he essentially lied about an episode of meth-induced psychosis he had had more than a decade before he started use, which of what seemed like appropriate use at the time, prescription stimulant use to treat his ADHD. It actually did treat him successfully. He was finally able to return to college, complete his degree, and get a much more suitable and challenging job. And it was a year into that job, a few years into prescription stimulant use, that he developed full-blown psychosis. Third reason I have probably more than the average practitioner or an elevated rate of seeing amphetamine-induced psychosis is that I am identified in databases as insurance-based and otherwise as someone who works with ADHD, who is willing to prescribe stimulant medications. And getting back to the fourth horrible point about amphetamine-induced psychosis, the fourth point is that many people who've had an episode of this, including being hospitalized, which is hard to get in this day and age, you have to be pretty out of it and pretty dangerous to yourself or others to get into the hospital. Many of these people, and again, even though the state itself, as I've seen, is characterized by fear, anxiety, paranoia, not by joyous mania or exuberant, uplifted spirits, many of these people want to keep using stimulants. I have received calls from a young man in his 20s who was hospitalized for amphetamine-induced psychosis. He had convinced his inpatient psychiatrist that it was a good idea to treat his ADHD to get back on it. She didn't actually have an outpatient practice, but he called me. I had only seen him once before when I prescribed him, but he wanted to resume using. A few years back, I saw 3 different 20-year-old men in the same year who all found my name through insurance or other databases, who wanted to get back on stimulants for the ADHD, even though all 3 of them had had multiple hospitalizations for amphetamine-induced psychosis. 2 of these individuals clearly lied and tried to hide their past history. So again, so those are three reasons. Again, I see more of this than the general practitioner, general ADHD practitioner probably, or the general psychiatrist, but I think it's important that I share, and I may be overly concerned. I, again, see it more than other people have seen it. But I think, again, it's worth being worried about rather than sort of blasely dismissing it as not very common. So a couple, again, one of the things I've mentioned is we don't have a lot of good research on this. There's speculation that, again, I think there's pretty good developing evidence that the amphetamine-based products are more risk than the Ritalin methylphenidate-based products. This does not seem to be a particular risk with Strattera, Wellbutrin, some other antidepressants or other medications that can effectively treat ADHD. There's been a lot of commentary and discussion on pretty clearly the immediate release forms of our stimulants seem to have higher rates of substance abuse and addiction. There have been claims that the immediate release have a higher potential for causing amphetamine-induced psychosis. I don't know any data that speak to this fact. I mean, it makes sense that if you're reaching higher peak levels or causing more toxicity in dopamine or other catecholamine systems, maybe you're causing more damage, or maybe the rapidity of big doses coming on and off receptors is a vulnerability. On the other hand, there have been some researchers who said theoretically maybe our risk is higher with the extended release because we are occupying those receptors more for greater period of time, greater percentage of the time. And again, there does seem to be both a dosage effect in terms of bigger doses seem to be more potent at causing psychosis. And again, I didn't mention this before, there were studies going back several decades just looking at healthy volunteers, and if you up the dose of stimulants high enough, a substantial number of individuals will develop an acute psychotic reaction. So that's a well-known phenomena. What we don't know again is, so dosage is clearly part of the risk. Is there some lifetime exposure risk that's as important as the daily dosage risk? I've certainly treated some people for decades who did stably on amphetamine and Ritalin-based products who have not developed any problems. So jumping around or getting back to what can you do about this if you have it? So what is the treatment approach? The first parts of the treatment approach is immediately stop any prescription stimulant use or non-prescription street stimulant use. 2 is get on an antipsychotic. I've seen some reports or summary, which questioned whether antipsychotics have been effective. In all the cases where I've seen them being used, they appeared to be effective and that the symptoms did resolve within days. The third, my strong recommendation, and is to stay off stimulants indefinitely. There are at least one set of written reports of people who had amphetamine-induced psychosis who were retried with low-dose, slow-acting Ritalin-based products. And again, that possibly may be safe. Again, Ritalin methylphenidate may have no potential for this, but I would not feel particularly comfortable myself with that medication route. And I would absolutely, certainly, I would never retry anyone on amphetamine Adderall-based products if they had ever had a episode like this. Again, there is both some laboratory research animal data and some human data that does suggest even having one episode sensitizes the brain and there's more risk for having such a response again should you be exposed to stimulants again. Separate from the treatment, I think prevention is the biggest lesson here. And again, part of my preparation for anyone that I am prescribing Adderall, Ritalin, any stimulant products is to go through a talk somewhat like this. And given that part of what's intrinsic in any psychotic process is lack of touch with reality, you can't just tell a person, okay, sit and wait till you're paranoid. How do they know they're paranoid? They think it's real. They think that policemen really are under the steps there spying on them. They think someone is really, mother is poisoning their coffee in the morning. So it's what I tell anybody who's about to receive a prescription like this, you need to tell someone who is in your daily life, either a family member, a spouse, a friend, maybe even a coworker, maybe a therapist who's seeing you very frequently, about stimulants having a potential for risk for this. And if they are seeing any signs of this, they need to tell you to stop and get to emergency medical treatment. So I think prevention is the best recipe. I mean, along those lines, I am very reluctant to prescribe stimulants, and again, particularly Adderall-based products, to someone who is living alone, not having any interactions with other humans, and doesn't have someone in their life who can check up on them and keep things in track and help avert a disaster if we're seeing the early stages of a disaster. So that's about all I have to say for today about amphetamine-induced psychosis. I'm not seeing any questions coming in right now. I will stick around for another minute or two. The topic for next week is rejection sensitivity dysphoria. That is the short, it's a depressive-like constellation of reactions and sensitivity to criticism and low self-esteem that Dr. Dodson, who's a Colorado-based ADHD expert, has written extensively about. And I think it's a good concept. I think it's a useful concept, but I do have some objections I will raise to some of the construct as it has been framed. So have a happy Halloween, have a happier election day, stay safe, and I will be back next Friday. Bye.